Got it. Okay. Now. Yep. Okay. So I had the pleasure this year of attending the APTA CSM in San Antonio in person. And this particular presentation on therapy outcomes in post-acute care settings, one of the presenters was Jason Falvey, and I don't know if any of you got to meet him while he was doing his postdoc here at Yale, but he was working in the School of Public Health. And Jason is a PT. He teaches now down at University of Maryland down in Baltimore. And so this was a presentation that he had been involved with. So the study was jointly commissioned by the AOTA and the APTA. It's a first of a kind study that showed physical therapy and occupational therapy are connected to positive impacts on patients in post-acute care settings, including improving the functional ability of patients and reducing readmissions to acute care hospitals. The study reviewed data from 1.4 million Medicare cases that were made available from the Center for Medicare and Medicaid Services. The findings have implications for CMS, ongoing implementation of post-acute care, payment system reforms, as well as any future unified prospective payment systems. So, you know, this is big stuff. The problem with this is that the data that they made available is stuff that's about 6, 7 years old at this point in time. So, but it's the first time that they really unlocked all of the data for a time period and we're able to evaluate it. So the disclaimers, this is a data that was between January 2015 and December 31st, 2016. So, and this is just a kind of a taste of the entire presentation. This is short, but I still kind of wanted to show you something right off the bat. I kind of call this like the Goldilocks syndrome here. And what they were looking like in this slide, it's an example of the findings of the study. SNF residents who received high intensive therapy, defined as 90 to 219 hours across all conditions, had the lowest rates of 30-day hospital readmissions. So, basically, if they looked at groups where the intensity was low, people that participate much in therapy in a SNF, readmissions were much higher. If they were typical, and that seemed to be kind of the just right size there. And then high intensity had the lowest readmission rates. So the objectives of the study, demographic review of patients in the study in relationship of the intensity of the care and the outcomes, improve function and reduce readmissions is the primary focus of this study. Demographic considerations include race, ethnicity, gender, age, dual age, in other words, people who had both Medicare and Medicaid complications, and diagnostic groups. The service intensity is grouped in low, average, and high based on actual utilization rates and outcomes regarding functional status change in readmissions. So, key finding number one, distinct people with complex conditions and comorbidities received OT and PT in each PAC setting. So when we talk about the PAC settings, it's home health, it's an IRU, and it's a SNF. So people that were aged 65 to 74 were more likely to get home health. In the age group 75 to 84, it was equally distributed. And in the 85 plus group, you could see that SNF, the kind of the medium blue was the, although our little Zoom thing there is kind of blocking it. It was definitely people 85 plus was primarily in the SNF. SNFs had the largest proportion, more than home health and IRUs or IRFs, for dual eligible patients receiving therapy services. Nearly half of the people in SNFs who received therapy had dementia, compared to 20% in home health and 31% in IRF. Depression was common in all settings. More than 40% of people receiving therapy in a SNF or an IRF had a diagnosis of depression. Nearly 1 in 4 in home health were admitted to the ICU during hospitalization, 30% going to SNFs and 40% going to an IRF. As logic might dictate, the median functional status of patients admitted to a post-acute setting is highest in the home health and lowest in the IRF. So in other words, the more functional you were, the more likely you were to go home. Duh, we kind of know that. Although all major diagnostic groups are served in each setting, some groups are more prevalent in specific settings. Nearly half the people with stroke received care in an IRF. Nearly half the people with CHF received care in a SNF. Almost 2/3 of the people with joint replacements receive home health. And you've seen that, for those of us who've been doing this for 10+ years, you've definitely seen that transition with total joints away from anything but home health. And, with the other 2 diagnoses, it's kind of because that's where they're going to be best served. Finding number 2, the intensity of OT and PT services is associated with improved ability to perform everyday functional activities such as bathing, dressing, and transfer. And then the third finding is that people who receive the fewest minutes of PT and OT were at the highest risk for hospital readmission across all post-acute care settings. So these findings were consistent for patients with medical and surgical conditions, suggesting a robust impact for Medicare populations. So think about this for a second. United Healthcare, all of the managed Medicare groups that are trying to whittle down the amount of therapy that they're approving in a PAC setting. Nursing homes are fighting up. Nursing homes used to be able to say, oh yes, we do 7 days a week, but United Healthcare is only going to pay for 5. And so then the therapist started saying, well, then don't put them on for the weekends. And so, as you start having these policies that limit the amount of therapy, the outcomes start to decline. So, this is pretty cool stuff for us. Readmissions after home health. So, looking at the graph on the left, it's showing that people at the lowest intensity of therapy services had the highest rates of readmissions. Those who had typical and high were about the same, 5.8 and then 5.6 for the high. So that's why I kind of called it the Goldilocks thing, because if you're looking at trying to figure out value, it's not necessarily throwing a lot of services at something, but it's kind of throwing the typical level of services that we've all experienced, if we worked in those settings. The same thing with changes in function in home health. So functional status change after admission to discharge. And really all that we're looking at, if you've worked in those settings, you know what the GG codes are? So at the beginning, you're, and you do it in home health, you do it in the SNF, and it's just looking at functional status at the start and functional status at the end. And the low intensity group had the least change, and the high intensity group had the greatest change. In a skilled nursing setting, the same phenomenon, where you'd see the readmissions are lowest with the typical and the high intensity groups. And actually, in terms of functional status, and this is with a lot of data. So can't see the last bar, but basically it represents that the functional status change for the low intensity group was 1.83. The typical group was 3.5, and the high intensity group was 3.3. And then in the IRU, readmission rates are highest in the low intensity group and lowest in the typical and the high intensity. And the same phenomena that we saw with the SNF was that the greatest functional change was actually in the typical intensity group, where you saw 14.3 change. So, you know, greatest change in the IRU, obviously, because people are coming in more declined than they would either at home or in a SNF. And, but the typical intensity group, and, you know, we need to share this data because, you know, obviously the United Healthcares in the world, we want them to recognize that, you know, we do need to provide more therapy services in these settings, but also kind of looking at, you know, the value equation and saying, just because we throw a lot at somebody, it doesn't necessarily mean that, you know, that's going to be the best outcome. So key points, and I told you this was short. OT and PT are related to improve function. There's clear evidence that therapy services improve patient outcomes across all PAC settings. I know I'm preaching to the choir. So suggest high potential of harm to patients who receive the fewest minutes of therapy. And the need to match delivery of therapy services to the patient's needs. You know, as you drill deeper into this here, you look at CHF, at stroke, you know, there's some more specific findings, but the trends are still the same. OT and PT are related to reduced readmission. 30-day readmission rates following a PAC episode decrease after therapy and appear to have varying threshold effects within each setting. Readmission rates help to reflect whether patients are receiving appropriate levels of care following discharge from the hospital. And patients who receive PT and OT during their initial PAC episode are less likely to be readmitted and more likely to have better outcomes. You know, like I said, preaching to the choir, but yet in order to direct policy, APTA, AOTA, you know, they really need to drill this stuff home to policymakers because, you know, we're constantly fighting, you know, right now the big fight is whether or not, you know, PT and PTA and OT and COTA services are going to be valued the same versus, you know, being reimbursed differently. And, you know, that's the newest thing. So, questions?
Did they define like what was high intensity, like a number of minutes?
Again, it varies by the setting. You know, like if you work in a, if you worked in a SNF, you know, like, you know, when you get to that ultra level, you know, it's usually like 720 minutes. In the IRU, you know, I'm not an IRU person, but, you know, I think what would be average in IRU? About 3 hours a day? Yeah, so, 15 hours. Right, so that would be the midline. So, you know, there are some IRUs that are thinking, well, if we spend 5 hours a day with you, it's going to be better. And they're not really finding that here. Yeah. But what they are finding is that, you know, either because the IRUs aren't providing that 3 hours a day, they're doing less, or because of, it might be participation by the patient or whatever, where there's less involvement, they're more likely to be readmitted. So they were kind of vague about it because what they looked at was like, instead of trying to define it, they looked at what are the trends. So, you know, this is obviously very low, and this is obviously very high, and then everything else fell in the middle.
Yeah.
Yeah, I'm curious about the IRU one because they typically have to have a minimum of 3 hours a day, I think, over the 5 days. So people are getting less, they're not even really meeting that criteria for IRU, which they're probably either sicker or, you know, because they're medically on hold or.
Right.
So that kind of makes sense why they would be admitted more often.
And sometimes, you know, they're just not appropriate, you know.
Yeah.
When you get a readmission to the hospital, it might be because they were probably inappropriate to discharge to begin with. And then if you're throwing less services at them, they're more likely to be a losing bet. You know, it's all common sense, but if you don't, you know, formulate it in this way in order, this is the stuff that's gonna help to direct policies and hopefully, make life a little bit easier in the coming years for people across those, who need those services.
So for the readmittance, did they talk about what they were readmitted for? Was it something pertaining to the same condition, or did they just follow cases in general? It didn't look at that aspect.
They just really, the key things were just looking at the demographics and then looking at the diagnostic groups and then how many got readmitted, what their outcomes were, but they really weren't trying to figure out the whys as much. The assumption here is that the why is you didn't give them enough therapy. Mm-hmm. Which, I think, that was the purpose of the study. So tons of data. I mean, to have that many, people can't say, oh, well, that was a limited study or something like that. It was really looking at, all the data that's commonly available. And what you're talking about is a little harder because now you got to dive into a chart to figure out, okay, what happened in this case? How they were looking at it. But it's a good question. That was one of the things that came up, when I was sitting. It was a 90-minute presentation. So obviously I gave you the Reader's Digest version of it. What they did there was they really looked specifically at each diagnosis. I just went by settings, but they looked at diagnosis group by setting. And, so it got pretty specific where you could see, like, for example, CHF is better served in the SNF setting. Total joints are better served in the home care, so that was the other thing that came out of it that, of course, we already know because we're directing that. The nice thing right now is that here at Yale, we're doing some of the same, we're collecting same information and then really looking specifically, like it started with the frail hip program a few years ago, where they were looking at when we discharge people specific to particular nursing facilities, what were the outcomes? Of course, the samples are smaller with that, but it directs our care here in terms of where are we going to send to a 3-star facility or a 4-star facility. So, but it's really the same type of thing at a local level.
And they know more stars because patients. Oh, you can look it up. And they stay there.
CMS website, it's all public domain.
Well, you look at the place in Wallingford that just got shut down. Okay? That was not a 4-star facility. Yeah. It does come up. Like I do a little bit of home care, and the message I got in the home care setting was that, sometimes we as there, you could do the same thing when you're doing your 6 clicks or whatever. Do you overrate or underrate your patients? And since home care facilities and SNFs are part of their stars are based on the functional change, they're telling you, don't be so generous with looking at functional ability people when you do an evaluation. Yeah. But I'm not saying to game it, but it's, sometimes you really need to, in the moment, like if you open up a home care case, you kind of need to look at the case and say, today, right now, where are they? Not where do they want to be in a few days because they're highly independent. Where are they right now? And, and then kind of do their GG codes or whatever functional assessments you're doing based on where they are in the moment. And I think, we got to use the same argument when we look here in the hospital. The labeling I think is always funny when I hear, and you can hear it across any settings, I made the patient independent, right? We use that in therapy sometimes. To me, it's so freaking stupid to say that you didn't make them independent. Patient might be stubborn and just says, screw you, I'm going to do what I want to do anyhow, so I made myself in. But, but when we do that, it's like, okay, it's, however we rate somebody on the 6 clicks or whatever should be based on where they are in that moment, not where they need to be tomorrow or the next day. So, and, that can influence, functional assessments like this too. Good stuff.
Yeah. Thanks, Roland.